All right, we're going to get started again. We got a 23-minute video for you guys to watch. When we get done with this, we're going to go into our infectious disease talk. That'll take probably about another 20-30 minutes. And then I believe Corolla's up at 2 o'clock with pediatric restraint or something. And then at around 3 or shortly before 3, we will get into the skill side of things. Folks online, we're going to try to get you involved in the skills. If it does not work, you will all be getting emails from me with some certain videos to watch so you can get your full 20 hours of credit for this refresher. So if we have any questions on that, just please let me know. But we've got you taken care of. Everybody that sits here for the whole 3 days, you'll get your 20 hours. So, all right, without further ado, we're going to start our video.
Hi, my name is Stephanie Preister, and I'm going to talk about emergency management of cardiac arrest. I'm a nurse practitioner that works at Sanford in the Cardiovascular Institute. The first thing I wanted to start with is just how important cardiac arrest is outside of the hospital. And the one thing on this slide I want you to concentrate on is that the overall national survival rate from out-of-hospital cardiac arrest is approximately 5.6%. So it's not good, the survival rate. Most of the episodes of out-of-hospital cardiac arrest happen in adults and happen at home. And the most common victim is a male who is between the ages of 50 to 75 years of age. So when a cardiac arrest happens in a public place, it's usually an arrhythmic event that happens that's caused by a structural heart abnormality or some kind of electrophys disturbance in the heart. If you think about it, when somebody's out in a public place and they have a cardiac arrest, they were feeling quite well. That's why they were out in a public place participating in events, and they just go down. So it's usually something fast. It's the VT, VF that happens. A lot of times if they do go into ventricular tachycardia, it's pulseless and it eventually turns into VF, or sometimes it's just primary VF2 where they go down. The cardiac arrest that happens at a patient's house is usually secondary to other medical conditions. However, about 25% are still found to have VF as their initial cause of the cardiac arrest. PEA, which we're going to talk about later, that consists of an organized rhythm without a palpable pulse, and that's become more of a common clinical presentation in these cases that happen at home. When the initial rhythm is asystole or profound bradycardia without a pulse, the survival to the hospital discharge is very rare. So there's a lot of words on this slide. I apologize for that. But I want you to know that the single most important factor of survival is the time that a person has cardiac arrest until they are defibrillated. It's very important to restore that rhythm. And you all learn that in BLS and ACLS also to get the defibrillator as fast as possible in these situations. So key points here. The likelihood of survival is relatively high in rhythms that are, come in pulses, VT and VF, if it is witnessed, if we give fast CPR and defibrillation, if when that's indicated. That's actually relatively high for them to be for us to resuscitate them and them to survive. Outcomes in many locations with EMS systems cannot provide defibrillation until 10 minutes. That changes a lot. So if a person cardiac arrest and EMS cannot get there within 10 minutes and start, your basic CPR and advanced life support, the survival rate is less than 10%. Also, chances of survival every minute from the time that the patient collapsed to defibrillation diminishes by 7 to 10%. So time is a key factor in this for sure. The out-of-hospital chain of survival. So the first thing here is there's 5 chains, obviously, and we need to recognize that there's a problem and activate the emergency response system. Obviously, start immediate high-quality CPR, and then defibrillate if that's available. And then that's when you guys come in. That's when, you guys arrive, and then you guys take that over and do basic and advanced cares also, and then we get them to a hospital, ED, cath lab, ICU. So we have to make sure that we have every part of this chain as optimized as we can get to achieve the best outcomes possible and hopefully get the patient to survive. I'm not going to go into, BLS and, how many compressions to do, when to switch partners, all that stuff. That's stuff that you learn in BLS, and I'm not going to go through a lot of the ACLS stuff. But I will point out that chest compressions are very important. They help deliver blood and oxygen to the myocardium, and they also decompress the RV, the right ventricle, because that usually fills up with a lot of volume because it's overloaded from the venous return. So when you're doing compressions, not only are you delivering that blood and oxygen and circulating it, but you're decompressing the right ventricle. That's huge. And then also, even a brief pause or delay in performing chest compressions can really make a difference in if they survive. So let's say we're going to go into, let's say you do BLS, you do ACLS, you get the patient responding again, or at least you get a rhythm and a blood pressure and all that. We're going to go into what's going to happen after that. First of all, cardiovascular disease is the #1 cause of death in the United States. And many times it's the first indicator of the disease is an acute coronary event. So people don't even know they have cardiovascular disease until they have that big MI, and that's when you guys are involved then. Cardiac arrest is the most severe symptom of the acute coronary syndrome. So a lot of times people come in with chest pain and we catch it a little bit, but when they really are having that bad MI, it's usually cardiac arrest. Here's just a little anatomy. And this talks about, how the rhythm works in the heart. You have your sinus node, and that, of course, generates sinus rhythm. And then you go down to your AV node, and then we're not going to get any further, but then you go to like the bundle of His, and, it travels down, and then it contracts the LV and the RV at the same time. And that's how it all works. And when that gets disrupted, that's when you end up having a cardiac arrest. So sudden cardiac death is an electrical disruption of the heart's natural rhythm in which the heart stops beating altogether. It's not the same as a heart attack. A heart attack is a blood clot. So the blood clot happens, it hits the muscle's dying, it's not going to squeeze anymore. Then the heart's like, the electricity in the heart's like, what's going on? And it just starts quivering. It goes into an arrhythmia. So sudden cardiac death is different than a heart attack. A lot of times when people have sudden cardiac death, they are completely asymptomatic and they don't have anything prior to having the cardiac arrest. Sometimes people do have symptoms prior, and those include palpitations, shortness of breath, chest pain, syncope. Remember this one because there's a lot of patients who don't have any symptoms, but then they pass out and then they think it's due to something else, but it's really just a heart attack happening. A lot of women present with syncope. So when you come to a scene and you don't have all the symptoms aren't adding up, but they were syncopal, you got to think in the back of your head that it could be a heart attack happening. Cardiac arrest, they can be asystole, no rhythm at all. That's not shockable, remember. You just do basic BLS for that, compressions. VT, it can be pulseless VT, that's cardiac arrest. Ventricular fibrillation or PEA, which is very tricky. So ventricular arrhythmias, there's your non-sustained VT, monomorphic or polymorphic. And again, you'll get this when you have your ACLS. But I want you to know one thing. When we say non-sustained, it's always 30 seconds or less. That's the definition. So sustained VT is 30 seconds or more of VT. And you can have non-sustained VT, monomorphic or polymorphic, or sustained VT, monomorphic or polymorphic. You can have torsades, which torsades is not, it's not like your VT that has a pulse. If someone's in torsades, they are passed out. They're going to be out, just like VF. You have ventricular flutter, ventricular fibrillation. Those are the rhythms why somebody would have a cardiac arrest. PEA is very difficult. So it's all about, you hook that patient up, they have a rhythm, but there's no pulse. And it's very confusing because then you wonder, well, are we dealing with something neurological happening? Oh, wait, they're not breathing either. Oh, wait, you check and there's no pulse. So you can't focus exactly on the rhythm you're getting. My experience in the hospital so many times is we walk into a room and we're like, oh, look, they're just fine. They're sinus rhythm in the 80s, and they are not fine, and it's completely pulseless, and we have to start CPR, and it's a cardiac arrest. So that's one important thing. Don't always concentrate on the rhythm. When you're transporting somebody to the hospital in an ambulance, always look at your patient too. Just don't concentrate on that monitor. Like it says here, cardiac arrest for PEA is when there's electrical cardiac activity. So think of the heart, and there's electricity going through the heart, but it's not squeezing. The heart's like, nope, I don't care how much electricity you give me, I'm not going to squeeze. That's PEA. What are the causes for PEA? You have the H's and the T's, and these are good to just have like charted down somewhere. Hypovolemia, hypoxia, potassium's high or low, hypoglycemia. You got to think of drugs, tamponade, tension pneumo, a PE. PE can cause PEA. That might be one of the big causes out there that we need to keep in the back of our heads. And then trauma, tachycardia. So post cardiac arrest care, when someone comes in and they have cardiac arrest, when do we take them to the cath lab? That's an important factor here. And if you read these 4 statements, and you can see right behind them, like, class 1 level of evidence. So I'm going to actually go through them here. So a coronary angiography should be performed emergently rather than later in the hospital stay or at all for out of hospital cardiac arrest patients that you think is cardiac etiology of arrest or there was ST elevation. They should go right to the cath lab when they come in. Now, the next bullet down, emergency coronary angiography is reasonable for some adult patients. Let's say you bring them in, they're comatose, you don't have ST elevation on the EKG, you still suspect that, there's a cardiac origin. So that's reasonable to take them straight also. That's a class 2A level of evidence B. The next one, coronary angiogram is reasonable in post-cardiac arrest patients for whom it's indicated, but you don't know anything. You don't know if it's cardiac, you don't suspect cardiac. They don't have EKG changes, but they did arrest, whether they're awake or alert, it is reasonable to take them to cath lab. And then avoiding and immediately correcting hypotension during, like, you get the patient back, you want to get their systolic above 90 or their MAP above 65. That's a class 2B. So that is definitely reasonable to do. It's not a class 1, but it's a class 2B. You increase the blood pressure, you increase cardiac output. And when you increase cardiac output, you increase perfusion. Excuse me. So this is an algorithm that talks about immediate post-cardiac arrest care. And if you look at this is after you get them back. So let's say you're in the field and you do, BLS, ACLS, you get the patient back. So now what do? You're on your way to the hospital. You optimize the patient by ventilating and getting their oxygen saturation above 94. Do not hyperventilate. That is huge. And then you consider advanced airways also. Back in the day, I remember that was one of the things that we actually thought was helpful, like way back in the early 2000s, to, hyperventilate them, but it's actually is considered harmful. And then you want to treat their hypotension any way you can, maybe IV bolus, normal saline, LR, whatever, and then also vasopressor infusion, and then get the 12-lead EKG. So you're doing all this, if you can, before you even get to the hospital. Here's the next step. Are they following commands? You got them back. Yes, they're following commands. Great, they're going to cath lab. No, they are not following commands. We're going to induce hypothermia, and that's what the next slides are going to be about. Either way, if you look down, even if you induce hypothermia, you're still going to take them to cath lab, and then after that to critical care. This is just a slide that shows you, it's kind of like a little cheat sheet slide, And I kind of talked about this on the slide prior, but if you look at like IV bolus, you can do 1 to 2 liters normal saline or LR. Epi, what's the infusion on that? Dopamine, what's, you know, what can you do on that? And then norepinephrine. And I don't know how many, like, some are just basic, you know, EMS, or, you know, paramedics can do this and stuff, but just to know that these are available out there, and, you know, this is kind of like a cheat sheet for you. And then there's also those reversible causes that I talked about before for PEA. Reperfusion injury, you need to know tissue damage that's caused when blood supply returns to the tissue after a period of, you know, lack of oxygen. So that's reperfusion injury. Obviously, you're gonna get the oxygen back to those tissues, but it might not help, and that tissue might already be damaged for life, or it might improve too. We just never know which way that's gonna go there. The absence of oxygen during the ischemic period, so during the heart attack or cardiac arrest, can lead to inflammation and oxidative damage. And I'm going to talk about that in a couple slides coming up also. And then individuals suffering from an ischemic insult, they actually continue to suffer some injury even after circulation is restored. So that's why we maximize everything we can. And then that's when medications come into play. So a little hypothermia history for you. It was actually started way back in the day. You know, soldiers were packed in snow and ice way back in the day in the 1950s. They were protecting the brain during surgery by cooling them down. And then they thought, oh, wait, there's really no benefits. And in the 1990s, there was stuff done on animal models. And then 2002 was when they started doing like the randomized clinical trials. So it's just to show you that, you know, it's kind of been around, kind of like CPR has been around for, you know, hundreds of years, just different ways of doing it, until the early 2000s, and that's when hypothermia started to get studied more. So on this slide, I'm just going to click all through these here. I want you to see the very end of this, right there. So look at where this all meets. If we do hypothermia early, not only does it lower the metabolic rate and less oxygen consumption, but look, it stops that glutamine release and the calcium shifts, and then it stops the cell death. So that's the whole point where this all comes into play. If you see the red X's there. Oh, yep. So that's the whole point that we do hypothermia therapy, is to prevent cell death. This was a study out of Critical Care Medicine magazine. And if you look, what are the outcomes if you do hypothermia therapy? And the solid line is the hypothermia therapy, and then the dotted line is the standard resuscitation. And you have a way better chance of a good outcome with hypothermia therapy. But if you look, they both follow down on the slope there. So even after 60 minutes of both of them, I mean, if we don't have them both, or if we don't have hypothermia on board, the probability of a good outcome is just as good as your standard resuscitation. So time matters too. That's what I'm trying to get at here. So you can't just say, oh, we can have all the time in the world, we're going to cool them. We still need to work on time and also get them cooled if they are candidate for that. And then here's another slide that just proves it's good to hypothermia for coma after cardiac arrest. And that's the survival percentage on the left side there. And if we cool them, they have a better chance of survival and their outcomes are better. And this is measured in days. So not only is that, but if you look when the line starts splitting the most is right after about, well, I don't have the markers there, but it's probably about day, 3, 4, 5, their survival is better, but they're way better at day 50 of still being alive if we cool them down. So then how do we cool? Because we get this question a lot. And I know that when you're in the field, I'm going to talk about how it's not recommended right now to do pre-hospital cooling in patients, but eventually it very well could be. But when we do cool patients, excuse me, we do it at a temperature between 32 degrees Celsius and 36 degrees Celsius. And then we maintain it for about 24 hours after we achieve that temperature. And again, right now it's recommended against the routine pre-hospital cooling of patients, but you just never know. That was like a class 3, they saw no benefit, but things change and studies change. So what do we do when we're going to cool a patient? Obviously, they need to be intubated. We get an ART line in place. We get a central line in place. We insert the temperature sensor with a Foley catheter. So these are a lot of things we do. We sedate the patient with medications, and we also paralyze them with some VEC. Again, target temperature 32 to 36 for 24 hours after reaching the target temperature. So the goal is to get them to that temperature within 6 hours. We don't want to just cool them within like 30 minutes, but we want to get them to that temperature within not 24 hours either. So 6 hours is the goal. There's a lot of different ways to cool a patient. And the ones we use in the hospital are mostly the surface cooling devices and the intravascular devices. But there's, even like packing them with ice or cooling blankets and cool IV fluids. There's a lot of different methods out there to use. Here's just some examples of what's available. And it's not a fun thing. I mean, it can cause skin problems too, and it's a lot of work to cool them for 24 hours. Again, how do we do it? There's 3 phases: the induction phase, the maintenance phase, and the rewarming phase. And then it kind of says under the induction phase, we paralyze them. We try to reach that target temperature within 6 hours. We don't want to overshoot. The maintenance phase, we just maintain that temp and make sure we don't have any complications. And for example, skin complications is huge with that. And then we get to the phase where we rewarm them. So this is a trial this was a study, I should say, that was out there. It's a trial for pre-hospital mild hypothermia. We're not going crazy, but we're going to do pre-hospital mild hypothermia and out-of-hospital cardiac arrest. And it wasn't a negative study. It did say that a larger study is needed to prove this, but just be aware that this might come later in the future, but not currently, but to know that it is being studied and looked at more. Right now, to my knowledge, it's not part of the role at all, but it would be neat someday if we could start this process before they ever get to the hospital. And I know that there's been some talk, and I think even some trials lately in the Midwest going on about that. So pre-hospital hypothermia, more research is needed. Current evidence does not support the administration of therapeutic hypothermia in patients with out-of-hospital arrest. However, it appears that mild hypothermia protocols are safe, but there's no current guidelines in like the AHA or the ACC that's present right now. So conclusions: out-of-hospital cardiac arrest is very significant. And like my very first slide said, only 5.6% will survive those. It's an ongoing problem, and it's something that needs to be taken very seriously. Therapeutic hypothermia has been proven to improve survival and neurologic outcomes. And then therapeutic hypothermia should be implemented early and with organized treatment. And one of the things I did not go through here, just because I know you guys get it on a regular basis and you guys are up to date, is your BLS. And that's actually the most important thing to do for out of hospital arrest, is to start with your BLS and get them to the hospital as fast as you can. And then these are some of the things that we kind of do after they get here. That's actually all I have. If you have any questions, let your supervisor know, and they can get a hold of us here. Thank you.